just go down.
So what increases our health risks? It's the same body that actually looks at that defines our standard risk, looks at what increases our health risk for alcohol abuse disorders, and that's everything from minor withdrawal symptoms to DTs to just substance abuse, because alcohol is considered a substance. So they pretty much looked at all this data and they said, okay, men under the age of 65, if you drink 14 standard drinks per week, or more than 4 drinks on any day. I know that math doesn't really add up, but this is from their data. 14 standard drinks a day for a male pretty much increases your health risk. Not necessarily saying that these are the people who are going to have DTs, but it increases your overall health risk associated with alcohol abuse. And in women, it's about half that amount. 7 drinks per day, so that's about one standard drink per day, or three drinks any given day increases your health risk of alcohol-related health issues. So what is the pathophysiology of alcohol? So alcohol, we all know, is a central nervous system depressant. How does it work? So alcohol enhances your inhibitory tone through your GABA receptors, and it inhibits your excitatory tone through your NMDA receptors. And it's only the constant presence of alcohol that preserves this homeostasis. So pretty much if you stop drinking alcohol for any given... Stop. This one? Thanks. If you stop drinking alcohol for any given time, it can unmask this kind of chronic suppression that we've already been used to. So pretty much you can have this, instead of having this inhibition of this excitatory tone, you now have this release of this excitatory tone, and you have this, it exemplifies itself in more in excitation, so tremors, agitations, diaphoresis, and stuff like that. So pretty much like we're saying, alcohol is pretty much, it works on your GABA receptors. It's a major neurotransmitter in the brain. It binds, the binding site for alcohol is found on your GABA receptors. So pretty much alcohol works by increasing your chloride, it works on your GABA receptors to increase a chloride influx into your cells. And this pretty much creates this hyperpolarization that results in a global slowing of your neurotransmission. So that's why you get the sedative effects, seizure kind of like activity that you see with pretty much your alcohol. And so as alcohol tolerance develops, you are able to retain higher arousals at a higher alcohol level, because what you do is that you kind of downregulate your GABA receptors. So since there's less GABA receptors that are pretty much there, you have this, you pretty much become more awake with higher levels of alcohol. And when we talk about our NMDA receptors, pretty much alcohol works by inhibiting glutamate from working on your NMDA receptor. And like we said before, glutamates, NMDA receptors, their activity is pretty much a excitatory tone. So just by inhibiting your excitatory tone, you get kind of the same effect by enhancing your GABA tone. So you get more inhibition, you get more slowing of your neurotransmission, and you get the sedative effect that we also see. So the net effect, like we said before, by inhibiting your NMDA receptors, your excitatory tone, and enhancing your GABA receptors, all of this pretty much helps to cause a sedative, calming effect of all your neurotransmissions, as opposed to the excitatory effect that you have with your NMDA. So we look at our bottom charts. If somebody withdraws from alcohol right here, you can see that you have decrease of GABA, so you have decrease of your sedative effect, and you have more increase in your excitatory effect, and all this pretty much has the clinical symptoms of more symptomatic activity. So you get the seizures, you get the tremors, you get the hallucinations, you get the agitations. And this is more of a way of looking at our receptors in itself. So acute effects of alcohol. So when you're just drinking alcohol acutely, you have the same number of GABA receptors and you have NMDA receptors. And it's going to inhibit your NMDA receptors, and it's going to enhance your GABA receptors. And that's what the acute effects. So chronic effects, like we said, you get the downregulation of your GABA receptors. So you have less GABA receptors there, but you have the same number of NMDA receptors there. So when you have withdrawal And since you have less GABA receptors there, when you have withdrawal of that, you still have the same number of NMDA receptors. You get this excitatory tone that you tend to see with alcohol withdrawal. So like we said, just the agitations, the tremors, hypertension, and the seizures. So why do we like to drink? There was a study by Gilman that was done in 2008 that what he did was he gave people IV ethanol. These were just social drinkers. He gave them IV ethanol, and he looked at a functional MRI of their brain, and pretty much said, and it showed that when you gave people alcohol, alcohol pretty much rewarded, it activated your striatum, which is your reward center of your brain, and it's actually inhibited your amygdala, which is your fearful part of your brain. So what does that net effect kind of culminate to your liquid courage, right? So this is because alcohol makes you have this reward. You want to do it over and over. You feel very good when you're doing it. But at the same time, you feel less inhibited. You do not have this effect of really trying to be fearful of anything that comes in your way. So that's why these are some of the net effects that you see with alcohol, and I was able to show some of these on a functional MRI also. So some of our clinical symptoms that are associated with alcohol. So alcohol withdrawal is pretty much defined by our DSM-5. Remember when I was in medical school, it was DSM-4. But pretty much it comes out to cessation or reduction of your alcohol use. So it's not only just stopping use. So if somebody was drinking, a fifth of vodka a day, and then now they're drinking just maybe half of that, that's a significant reduction in their alcohol use. So that can still pretty much predispose them to alcohol withdrawal symptoms. And pretty much so you have cessation or reduction plus two or more of the following criteria. So autonomic hyperactivity, increased hand tremors, insomnia, nausea, vomiting, agitations, anxiety, or seizures. So two of those plus just a reduction or a stop in the use of alcohol is pretty much the definition of our alcohol withdrawal symptoms. So symptoms. So alcohol withdrawal symptoms usually begin 6 to 12 hours after the last drink, or like I said before, a sudden reduction in their alcohol intake in chronic alcohol drinkers. And they can range from mild symptoms to DTs, and they don't always follow a clinical course. So people don't always go into mild symptoms to hallucinations to DTs. The people skip steps. There's not a defined kind of algorithm that people tend to follow. So the withdrawal symptom clinical course is very variable. Some of our minor symptoms that we tend to see, we have insomnia, tremors, anxiety, headaches, diaphoresis, palpitation. Usually these are like within the present like 6 hours after stopping drinking. It usually resolve within a day or two. Seizures and hallucinations. So withdrawal seizures, they are, a lot of times when I was looking at some of the literature, they always called them as rum fits, which I was actually trying to figure out why they called them as rum fits. Actually, it's a historical fact. They call them rum fits because sailors actually used to have seizures. They used to drink a lot of rums, of course, on the ships, and they used to have a lot of seizures, so that's what the name rum fits actually comes from. I thought it was an interesting historical fact. But withdrawal seizures usually happen within 6 to 2 days after the last drink, or like we said, significantly reduced. And usually people have these if they have a chronic alcoholism. Hallucinations, alcohol-related psychosis is pretty much when they start talking about auditory, visual hallucinations. And they can develop usually, within the first 24 hours of cessation of drinking is when you tend to see this alcohol psychosis that people tend to exhibit. DTs. So DTs, a lot of times I think DTs is one of those symptoms that we tend to misdiagnose a lot of times. Usually you do not get DTs if it's within the first 24 hours of cessation of alcohol drinking. It's usually within 3 to 4 days of the person's last drink. And it's a extreme stage of alcohol withdrawal. So you're on the other spectrum of really, really severe symptoms. So they have fevers, they have tachycardia, they have hypertension, hallucinations. They can have all that. But the thing that separates DTs from all is that delirium is always present. So if somebody has hallucinations, they have auditory visual hallucinations, and they're having tachycardia agitations, they're having alcohol psychosis and not DTs. Literally, you have to have some effect of delirium, and usually you will have this effect if you really if you really question them, they will have this effect. So the thing that separates DTs from the other is that they must at least have deliriums present during this episode and in the time period. So if somebody is delirious within the first 24 hours, it may be another cause of delirium. So alcohol-induced DTs is usually 3 to 4 days after their last drink. And like I said, this is usually how the clinical presentation presents, but they don't, like I said before, they don't always follow these exact stages. Like somebody can go from tremors and then all of it have seizures or DTs. They may not have hallucinations. They may not have seizures. But usually tremors within the first 6 to 8 hours, and they have hallucinations within the first 24 hours. Seizures within the first day to the second day, and DTs to usually three. Most say 3 to 5 days after the last drink. Yes?
Obviously, we talked a lot in the unit about diagnosing delirium. How do you differentiate? How does one differentiate delirium from hallucination?
I think that's a good question. It's probably a difficult question. I think if it's predominantly, they're at least awake and alert to respond appropriately, but they still feel as if they're having they can hear stuff or they can see stuff that's not there. I think the visual hallucinations is probably going to make us a little bit more think that this is more of a DTs, and it's probably going to be a clinical gestalt. I think the auditory hallucinations will probably be a little bit easier to distinguish between DTs as opposed to alcohol-related psychosis. But clearly, if somebody's having visual hallucinations, we probably just put them all together as having DTs.
Yeah, that's what I was thinking. It's just one of the outfit.
Yeah, they're mostly.
They know what they're seeing isn't actually there.
Uh-huh. That's what I would say.
Yeah.
This is pretty much the same diagram that I was just saying for, but the reason I put this diagram up is because I wanted to show you that a lot of these symptoms actually overlap. So it's not that one happens and the other doesn't happen. You can have a lot of these symptoms that are overlapping with each other, and they don't always follow the definitive timeline that we're saying. So what are some laboratory tests that we can get to kind of help us confirm alcohol, at least misuse or alcohol dependence? So we can get a CBC, look at their MCV. Clearly they have nutritional deficiencies such as B12 and folate, so they can have an MCV elevation. Higher levels of your transaminitis, 2-to-1 levels, what we've always been told, from your AST to your ALT. We also have high levels of uric acid and triglyceride. Alcohol actually increases your triglyceride production. You can also get a drug screen just to make sure that they don't have another concurrent toxin in their system that can mimic alcohol. They tend to have low electrolytes, low potassium, phosphorus, and magnesium, so they're also at risk for torsades because of their prolonged QT, so you can get an EKG too. So Michigan impaired driving law. It's actually, I thought it was actually interesting. What constitutes impaired driving in Michigan? So pretty much if you have a blood alcohol, if you're over the age of 21 and your blood alcohol content is greater than 0.8, you're considered to be driving while impaired. They have actually, Michigan is like one of the few states that actually have 2 levels of severity. So if your blood alcohol level is greater than 0.17, which it puts you in this category, extreme health risk, extreme crash risk, pretty much they give you a higher fine than if you were just to have some alcohol in your system and you was found to be impaired while driving. But any alcohol level and they feel you're impaired, you can still be fined for alcohol impaired driving. So that's just one of the things that I thought was interesting to know about Michigan's impaired driving law. So our treatment. So clearly, we always have supportive treatment, help orient patients, especially if they're in DTs, they're having any kind of delirium to a person, place, or time. Because, most of our algorithms follow with the C-wall, we want to make sure that we're not oversedating them and they're protecting the airway. We're monitoring their vital systems to treat these appropriately. And almost all alcoholics come in volume depleted. So adequate hydration is pretty important and is commonly observed in alcohol abuse people. Thiamine. So thiamine is an important cofactor in our metabolism of glucose and keto acids. It's pretty much used, and you can see the backward pathway. If you don't have pyruvate dehydrogenase and thiamine is not present, you can actually produce more lactate. So thiamine is an important cofactor. So pretty much chronic alcohol consumption leads to thiamine deficiency because they have poor nutritional intake. Thiamine is a water-soluble vitamin that is absorbed through our duodenum. So even states where people have some kind of surgery in their bowels, they can actually still have nutritional deficiency. The body can take between 30 to 50 milligrams of thiamine. That's just pretty much its stores. And so a person who is alcoholic would take about 4 to 6 weeks to pretty much deplete their whole thiamine stores. In any condition that has a poor nutritional state can place a patient at risk. I was looking at some of this stuff, and there was actually in 1996 there was TPN which has thiamine inside of it. There was a thiamine deficiency in TPN, and there was actually cases that were reported of people because they didn't have thiamine in their TPN, they actually got Wernicke's just because of that. So don't forget the nutritional intake that thiamine is associated with, or the gut absorption through your duodenum. So thiamine deficiency, what does it produce? Wernicke's encephalopathy. So we got the classic triad that we're always been told. Altered mental status, ataxia, and nystagmus or ophthalmoplegia. So ophthalmoplegia is pretty much you get paralysis of your extraocular muscles. So you get these kind of palsies, whether it's abducing, sixth nerve palsy or such. So you get this, like the picture shown before. This pretty much is a classic of ophthalmoplegia. So what is Korsakoff? So Korsakoff is pretty much a late manifestation of Wernicke's. Pretty much untreated Wernicke's or inadequately treated Wernicke's can lead to Korsakoff. And Korsakoff is pretty much a memory problem. It's easy to remember if you think of it as a memory problem. So they have anterograde amnesia. Pretty much they can't remember just recent conversations. So you have a conversation about somebody about a particular event. 5 minutes later, they just forgot about that conversation. So anterograde memories, and they don't remember just even simple things that happened in the recent past. They also got retrograde amnesia, and they mix some of their memories. A new event with an old event, they kind of mix that. So they have these things called confabulations. So Korsakoff is actually irreversible. So it's a late stage. So you want to treat people who have Wernicke's before they get to Korsakoff because it's a really late irreversible stage of Wernicke's encephalopathy. So how do we try to diagnose people with Wernicke's better? So there was a study that was done in 1997 by Dr. Kane, and he looked at 28 alcoholics, and he looked at the people who had neuropsychological assessment, and these were all patients that died, of course, and they also had a definitive neuropathological diagnosis, and he pretty much came up with a criteria that helped with the sensitivity of diagnosing Wernicke's encephalopathy, and it's pretty much the same symptoms we have with diagnosed Wernicke's, the classic triad, your ataxia, cerebellar dysfunction, altered mental status, oculomotor deficiencies, plus dietary deficiency. You can make an argument that means that every single person that comes into the ICU pretty much has Wernicke's, right? Because somebody's going to have some kind of altered mental status, they're going to be ataxic, they almost all have nutritional deficiencies. So then you can make the argument, are we undertreating or are we under-recognizing Wernicke's in our alcoholic patients? Which brings up the next topic, the banana bag. So our banana bag is 100 milligrams of thiamine with folate in your multivitamin and 5% dextrose solution. The multivitamin makes it appear yellow. That's why we get the term banana bag. So, is 100 milligrams of thiamine good enough to treat somebody who has Wernicke's? The jury's still out on that. There's really no literature that really shows a standard dose. Most of it is really from case series. But like we said before, we know that we need 1 to 2 milligrams of thiamine, and alcoholics are deficient. The banana bag has about 100 milligrams, but most literature cites that as prophylaxis. So alcoholics, the reason we give them banana bags is because they're at risk if you haven't diagnosed them with Wernicke's, they're at risk of developing Wernicke's. So try to replenish their stores. We give them the banana bag, which is 100 milligrams of thiamine. But when they looked at some of these case theories of patients who pretty much developed Wernicke's who were still getting treated with the banana bag, they still develop Wernicke's. So is this enough? You can make an argument that it's not. So based off of just really case series, they come up to the conclusion that we should just pretty much try to replenish their stores acutely in high doses. So one of the recommendations is given 500 milligrams of thiamine every 8 hours for at least the first 2 days, and then 500 milligrams daily until they are able to be more awake and take oral intake, and then 100 milligrams after that for at least their hospital stay, and usually as an outpatient where they will need to be followed up with. There's not really much data that really supports this. This is just pretty much from looking at, there was actually one study where they looked at it was about 50 patients where they actually looked at they were getting treated with the banana bag too, and they also developed Wernicke's, and they looked at their neuropathological diagnosis, and these people had Wernicke's. These people still have Wernicke's too, and it was adequately getting treated. Some of them didn't have the classic symptoms of Wernicke's during presentation. So, like I said, the jury's still out, but most people think that if you suspect Wernicke's, you should try to give them these high-dose thiamine. Benzodiazepines. So how benzos act? Benzos act by binding to the GABA receptors. They increase the chloride ions. They pretty much work in the same effect as our alcohol. They've pretty much been the mainstay of treatment for alcohol withdrawal. Numerous trials have showed that they have a relative risk reduction of 7.7 in preventing seizures and preventing delirium, and they prevent progression to least ET. So we know that benzos work, and they work well, so that's why they're still the mainstay of treatment. And how do we assess people who have alcohol withdrawal in the hospital? We use pretty much the clinical Institute of Withdrawal Assessment, Alcohol Revised, also known as our CWAL. It's 10 domains. Pretty much patients have to at least try to answer some of these questions, and they kind of categorize them into severity. So less than 10 is very mild withdrawals, 10 to 15 mild withdrawals, 16 to 20 is moderate, and over 20. So if you see a CWAL over 20, that's usually indicative of severe withdrawal. And this is our CWAL protocol. Pretty much the nurse is scheduled to give patients 2 milligrams PO or IV for a CWAL score of greater than 8. And they're to reassess every hour to see if they meet the requirement for another dose of Ativan if their CWAL score is over 8. If somebody's CWAL score is less than 8 for at least 24 hours, the nurse is pretty much going to change the algorithm to every 4 hours assessment instead of every 1 hour assessment. And then they're also going to, if you look at the other part of the protocol, if it's less than 8 for at least 24 hours, they're supposed to call you to consider you stopping the protocol altogether. So what about patients that are intubated and can't answer specific CWAL questions, like are they having headaches, stuff like that? What can we use? So one of the things that some of the studies use, not all of them use that, is the Richmond Agitation Sedation Scale, RASS, as we always know. So RASS is at least our way of assessing people's agitations, and so most of the studies try to look at aiming for a RASS score of 0 to 2, so anywhere between awakens to voice to very light sedation. They still are able to awaken to voice command, and so that's another thing that we use for people who are intubated, at least a RASS score. This is some of our dosing of some of the benzos that you'll see a lot in the literature. Most studies actually use Valium, which is your diazepine. Has a quicker onset of action, tends to work longer, but is hepatically active. So I actually emailed Mike. I was like, why do you not use Valium here, and why do we use Ativan here for our alcohol withdrawal? And he pretty much said because of our population. He said we deal with a lot of alcohol. We deal with a lot more cirrhotics and really bad liver failure patients. So his thought process was that since we deal with more liver sicker patients and liver disease patients, and diazepam and Librium are hepatically cleared, you can have technically a longer half-life with these medications. So he felt as if like lorazepam is a better drug in this population base, so they just made it a system-wide kind of policy, just because of the severity of the people we use and the fact that most of them have pretty significant liver injuries.
Jesse, I think that's kind of institution-based, right? We train for residency. We would routinely have of our whatever number of admissions, 2 of them almost inevitably would be alcohol withdrawal, and our protocol there used Valium, and we would use it up front as our loading for patients with high risk, and then would actually dose with that as well. So you can do it. I think the nice thing about Valium is because it is hepatically active, it may actually self-taper
longer, yeah.
And that there's some advantage to that.
And I think it's still institutional. Yeah, my old institution used Ativan, and when I talked to Dr. Jaffrey, he said that when he was in Texas, they used Valium. So it's very institutional based as opposed to what people are using for the alcohol withdrawal. You know, some people can make the same argument that it's going to last longer because it's not hepatically cleared, and that's why people actually like Valium better. So you can make an argument probably for both cases. It depends on who feels more comfortable with what drug, but I don't think any of them are pretty much excluded. It's just most of the studies will look at diazepam as opposed to Ativan. Just wanted to tell people why. So refractory DTs. What is the definition of refractory DTs? So refractory DTs is pretty much people are still having symptoms of alcohol withdrawal despite high doses of benzodiazepines. What is high doses of benzodiazepines? There is no study that has really clearly defined what refractory DTs is. You know, some people will say, like when Upstate pretty much had this exact, if somebody requires in the first hour 10 milligrams of Ativan, so that's about 5 doses of Ativan in the first hour, or about 4 doses of Valium in the first hour. That's refractory DTs. Or if in the first 4 hours they require at least 200 milligrams of Valium or 40 grams of diazepam, that's what they consider refractory DTs. But there's no clear defined criteria for defining DTs. Different studies use different kind of cutoff of what they think was a high dose of benzo. So, but you kind of use this as your gestalt of when we probably start thinking of somebody who's having refractory DTs, if they're requiring at least 10 milligrams of Ativan in the first hour, 40 within the first 4 hours of admission. Phenobarbital. So phenobarbital, it binds to your GABA receptors. It pretty much works similar to alcohol and similar to benzos. It binds to a different site, and it causes the same kind of decreased excitability state by increasing the influx of chloride, hyperpolarization, and decreasing neurotransmission. It also has an effect on glutamate and induces depolarization. So it works on both of the levels that alcohol tends to work on. So that's why there's a lot of interest in phenobarbital as one of the medications that we're using for alcohol withdrawal syndrome. So there was a study that looked at, this was an ER study actually. What they did was they randomized, it was a prospective study, they randomized patients to either a single dose of phenobarbital, so 10 milligrams of phenobarbital and 100 milligrams of IV solution, or placebo, which is just another 100 milligrams of IV solution. And this was in addition to their CWAL-based protocol. They started off with 198 patients. They ended up with 102 that met analysis, and 51 of those patients received phenobarb, and another 51 received placebo. The baseline characteristics were pretty similar between both groups. Patients that got phenobarbital as opposed to placebo actually had less ICU admissions. So like I said, this was an ER study that was looking at outcome of where these patients actually ended up. ICU, tele, floor, such and forth. So people who got the phenobarb went to the ICU less than people who didn't get the phenobarb. There was no difference in the adverse event, and their conclusion was a single dose of IV phenobarbital combined with your standard CWAL protocol reduced ICU admission rates. Some bigger takeaway, it likely provides some synergistic effect of phenobarbital and Ativan and alcohol withdrawal. That a single dose of IV phenobarbital decreased ICU admission rates, use of continuous lorazepam infusions, or total benzo dose. Like I said, there was no difference in adverse events between the two groups. There was another study, this was actually a Denmark study that looked at phenobarbital. It was a retrospective study that looked at phenobarbital in two psychiatric departments who received, in Denmark actually, phenobarbital was actually the drug of choice back in the day. They used to actually use more phenobarbital and less benzos. So what they did was they looked at psychiatric department when they was using the benzos. One used exclusive phenobarbital, and then one was using phenobarbital, and then they switched to benzos. And they looked at all these patients between almost an 8-year period. And the phenobarbital dose that they gave for the alcohol withdrawal ranged from 100 to 200 milligrams hourly. It was administered IV or orally. And what they noticed, there was no, mine is a retrospective study, but there was no difference in DTs, length of stay, complications with patients in a phenobarbital group or patients treated with the Valium group. Pretty much their conclusion was phenobarbital was just as efficient as Valium in treatment of DTs. So the big takeaway from this was phenobarbital is an alternative to benzos for the treatment of DTs. There was no significant difference in DTs, hospitalizations, no significant decrease in complications. There was a little bit more respiratory depressions in the phenobarbital group, 4% as opposed to 1% in the diazepam treated group. But what some of the studies was concerned about is that because of the barbiturate's narrow therapeutic window and because of their long half-life, phenobarbital has a half-life between 3 to 4 days. So because of the long half-life, titration becomes a little difficult, and people were more concerned about the increased risk of respiratory insufficiency. Mind you, this is a retrospective study, so you have to take that in mind. So but they were concerned of respiratory insufficiency and coma, and so that likely, if you were going to use phenobarbital, they were concerned that there will be increased risk of intubation and mechanical ventilation, but that was not one of the things that they was looking for in the study. Precedex. We always hear about Precedex and management of DTs. So how does Precedex work? Precedex is an alpha-2 receptor agonist. It works by it works by inhibition of your norepinephrine at your locus coeruleus. Your locus coeruleus is your adrenergic receptor in your brain. So by inhibiting your norepinephrine from your locus coeruleus, it decreases your central sympathetic output. And the net effect of that is you get this kind of increase in sedative, and you get this anxiolytic kind of pattern. You get decrease in blood pressure and decrease in your heart rate. So that's why we always notice a bradycardia and decrease in blood pressures with the Precedex. Precedex has no GABA activity, and that's a point to make out. So it has no GABA activity, so therefore it does not actually directly treat the underlying mechanism that prevents DTs and seizures. Pretty much what people are using Precedex for is pretty much the symptoms surrounding DTs. So your agitations, your autonomic hyperactivities, tremors, hypertension, and so forth. So the addition, so that's why Precedex, I haven't seen a trial where they looked at Precedex solely as a treatment of DT because it's that underlying mechanism that still kind of comes to the forefront of it. So it's an additive. Most of the studies are additive effects of Precedex to already your symptom-controlled seawall protocol. So that was another study. This was a retrospective study, cohort study. It was 61 patients that were non-intubated, and pretty much they looked at, they had two arms of this cohort study. They looked at people who were on continuous infusion of Versed or Ativan or Precedex, in addition to our standard seawall protocol. And then they looked at rates of respiratory depression requiring intubation and occurrence of alcohol withdrawal seizures. So there was no significant difference in respiratory distress, the benzodiazose, respiratory distress requiring intubation between the benzo and the Precedex, or alcohol withdrawal seizures. The total dose of benzos, of course, because you're in the arm that they're giving continuous doses of benzos, was higher than the Precedex group, 105 to 3. And Dex was associated, of course, with a little bit more adverse events like bradycardia and hypotension was significantly seen more. And at the time, one of the rate-limiting steps of the study was the Dex higher cost per drug, which we'll get to later. Some big takeaway so if you look at some of the data in the study, prior to the study initiation, patients in the benzo group had received higher benzo dose compared to the Dex group already. Greater percentage of patients in the benzo group received olazapine, so maybe they had a little sicker patient base than the Precedex group. The Dex group also received, of course, like we said, they received a lower benzo requirements than the benzo group. And even though they received a lot more benzos, it did not translate into more intubations, or they didn't have a decreased length of stay. What I thought was interesting, like I said, this is a cohort study. What I thought was interesting is that although Precedex does not work on GABA receptors, there was no decrease in seizures. But like I said, this is a cohort study, so just take that into the back of your brains on that.
Is there like CAN-LICU scores on people on benzos or something like that? Score for that group?
I'm not sure, to be honest. I'll have to go back and look to see if they did CAM scores. So there was another study. There was actually a lot more studies on Precedex. So there was another study, a double-blind placebo-controlled study that looked at Precedex as an adjunct to alcohol withdrawal. So this was 24 patients, pretty much who had refractory alcohol withdrawal, which they pretty much defined as 15 or greater than 15 or 16 in the 14-hour period of lorazepam, Ativan. And their intervention, people who were assigned to seawall protocol got pretty much assigned to Dex or placebo. And in the Dex group, they divided it into high dose, which is 1.2 micrograms per kg per hour, or low dose, which is 0.4 micrograms kg per hour. And the end goal was they were looked at them for 5 days or to resolution of alcohol withdrawal symptoms. So when they looked at these group of people, within the first 24 hours, the lorazepam dose in the Dex group was significantly lower than in the placebo group, 56, less than 56 to 8. There was no median difference between the high Dex group and the low Dex group. But after 7 days, there seemed to be some kind of tolerance that developed because there was actually no difference in the amount of benzos that were required at the end of the 7 days. Pretty much, it was no difference in the cumulative benzo requirements at 7 days. So maybe these people developed a tolerance to Precedex by the end of the study. Bradycardia, of course, was more common again in the Precedex groups, and the bradycardia was more significant in the higher dose Precedex groups as opposed to the lower dose Precedex groups. So their conclusion was Precedex pretty much decreased the amount of lorazepam, which would decrease your benzo requirements in the short term, but not in the long term when using a seawall approach protocol.
Jesse, in that study, do you remember if it was after the 5-day mark that they sort of caught up in the amount of benzos because they only gave the dex for 5 days, correct?
Yeah. So
When they said it was the same dose, but they just needed higher doses in the last 2 days when they came off the.
Oh, I didn't look at it that far. I just looked at it as towards the end there was a catch-up period. I'm not sure at what point there was a catch-up period, but at the end of the study they pretty much showed that they 180 to like 160. So at the end of the study they still required almost the same amount. So I would guess because in the first 24 hours there was a significant decrease in the benzo requirements. So somewhere between the second day and onward there was some catch-up period that the Precedex groups started to use a little bit more benzos. So some big take-home points was 11 of the 24 patients were already intubated prior to the start of the trial. So you could say that these people were a little bit more sick. You can argue that you could probably make an argument that the best time to use Precedex is probably early in the treatment to avoid intubations as opposed to late, especially since we require, if you remember, in the first 24 hours they required a lot less benzos than in the placebo arm. But then also there's also this point that should reduction in benzos be used as your endpoint. So if your reduction in benzos still led to the same number of intubations or the same number of ICU lengths, and you still wonder, is there any benefit to actually still using Precedex? So their endpoint, of course, was a reduction in benzos, but if the reduction in benzos still doesn't manifest to anything that's significant to total ICU cost or anything like that, then you can make an argument of is it actually beneficial? So there was another study on DEX. So this was a study that looked at DEX therapy in an ICU setting. So pretty much they put people into 2 groups, Group D, which was DEX, and Group C, which was just seawall controlled. And they looked at 24-hour benzo requirements and the cumulative benzo requirements over the course of their ICU stay. Secondary outcomes was ICU length of stay, sedation, communication quality, and haloperidol requirements. So within the median 24-hour diazepam requirements was significantly lower in the Precedex groups within the first 24 hours. So once again, we see that effect, like we seen in the previous study. As also was the median ICU benzo requirements over their ICU stay. So they required about 30 milligrams less of diazepam as opposed to the placebo group. So they had more time, and the Group D took a longer time for Group D to be in the required sedation than it did in the benzo group, which we see a lot because Precedex doesn't. I mean, it's a good sedative, but benzos probably have a little bit more sedative effect. The nurses actually like the Precedex groups better than the benzo groups for their nursing assessed patient communication. There was the same number of intubations and spontaneous breathing patients, and bradycardia was, of course, more common in the Precedex group as opposed to the benzo group, which, again, we see Precedex inhibition of their norepinephrine kind of effects that we see throughout the trials. So their conclusion was Precedex significantly reduced benzo requirements in the ICU with patients with alcohol withdrawal syndromes, and decreased the amount of haloperidol for severe agitation and hallucination. But of course, DEX was also associated with increase in nursing quality of patient communication, which I thought was a good point. So some of the take-home points I thought was from this was that if you look at it, was a 20 milligram decrease in volume a clinically meaningful reduction? So in the Precedex group, when you compared it to the placebo group, there was only a 20 milligram in the first 24 hours. So that's just 2 doses more in volume. Is that really a significant change? I don't know, but the nurses, which is very important to me, liked it better. So.
They keep track of the number of nursing assessments in the difference between the benzo
Yeah, they had a standard protocol of nursing assessment, so they did. I don't have the table, but they actually did have a standard kind of nursing assessment of patient interaction. Is that your question?
Yeah, well, because typically the reason they prefer drips is because they don't assess.
Ah, gotcha,
I mean,
gotcha.
like,
Yeah,
to
for
be
sure.
honest. So if there was a preference,
Yeah,
that's why I'm just wondering if that's why they have a preference.
yeah. That's a good point. That's a good point. They did have a protocol, so it wouldn't be so biased. But I don't know the exact point.
This one was for how long? They gave the dex. This is also.
This was just into ICU stay, so total ICU stay.
Okay.
Yeah, I know it doesn't really match up with the previous trial as the total amount of benzos requirements. So one of the rate limiting steps for the study was a cost of dex. So the cost of dex on average used to cost $55 per vial compared to $5 per vial for Versed. So I called pharmacy and I asked them how much is a cost of Precedex now. It's $8 a vial. So that really big, some of the stuff with, it decreases the benzo requirements. There's a 20 milligram decrease in benzo requirements significant, especially when the cost was almost, 10 times more. That was one of the biggest drawbacks back then. But now, being that Precedex is way cheaper now, some of that stuff is not as much of a factor as it was before. So pretty much the point to remember is that Precedex given IV has been tested as a good therapy to use in conjunction with Seawall for severe alcohol withdrawal syndromes, and has been shown to at least decrease the total benzo needed compared to just benzo therapy alone. But there has not been a difference in hospital length of stay.
Sorry, I'm just clearly not getting this, but did it decrease intubations? Did it?
No,
Oh, okay.
it didn't.
Just asking, because I don't really understand it.
But so mind you, there was only one of those studies that was prospective. Most of those were cohort or retrospective studies. So some of their endpoints were just literally benzo requirements or ICU length of stays. I'll have to go into the secondary analysis to see if some of these looked at particularly that weren't at least obvious in the initial data, particularly like rates of intubation and stuff like that. But it's probably a little bit harder, especially when you're talking about looking at severity, because when they're looking at retrospective, they're looking at severity just opposed to how many people have this much of benzos, whatever their cutoff was, and then they'll have to look at how many people were intubated. So it's probably a little bit harder as opposed to looking at benzo requirements and total ICU length of stay. So Propofol. I know. So Propofol has the same kind of GABA activity as we've seen with our phenobarbital and our alcohol. It works on our GABA receptors, increases chloride influx, hyperpolarization, decrease in neurotransmission, and it works the same. It antagonizes NMDA receptors also, but it just works at a different site. So Propofol there was a study that looked at Propofol as in alcohol withdrawal, alcohol resistant, benzo requirement resistant alcohol withdrawal, and they defined theirs as greater than 40 milligrams of diazepam within 1 hour. So that initial definition that we had for refractory DTs, this was their definition of it for this study. This was a University of Pittsburgh study, if I remember. So this was a retrospective study that looked at patients for about 3 years with their definition of resistant alcohol withdrawal. And they pretty much categorized these people into benzos or benzo plus propofol. And their endpoint was time towards resolution. And their secondary outcome was safety outcomes and medication use. So they looked at about 183 patients with severe alcohol withdrawal symptom, and they found about 66 that were refractory alcohol withdrawal, and 33 of these patients was benzos, and 33 of these patients were benzos plus propofol met this inclusion. So the median time between alcohol withdrawal symptoms resolution was 5 days in the benzo-only group and about 7 days in the benzo with propofol group. The duration of mechanical ventilation, ICU length of stay were significantly higher in the propofol group as compared to the benzo group. And 10 patients required intervention for propofol-related adverse effects from propofol infusion syndromes and such. So in this conclusion, they said that propofol in use in refractory to alcohol withdrawal was associated with increased significant clinical care and likely in higher hospital length of stay and more complications. So it wasn't actually a positive study for propofol. There was another study that looked at propofol with benzo regimens for alcohol withdrawal in intubated patients. And what they did, it was another retrospective cohort study where they looked at patients with ICD code 9 who had alcohol withdrawal, who required who were intubated because of the alcohol withdrawal. So they went through 1,600 charts, and 64 included. Most of them were propofol, almost 72%. The rest were benzos, 28%. The benzo dose given something to note was that the people who were in the benzo dose actually required higher amounts of benzos that were seen in the benzo group than the propofol group. So a little bias on that part. And then the time to resolution of alcohol symptoms for propofol and benzos were 8 to 7 days. So not a significant difference in the time of alcohol resolution of alcohol withdrawal symptoms. Their median ICU stays were similar. Their days were similar on being intubated, but this study didn't show any propofol infusion syndrome. No difference was found in reintubation or mortality. So how they read this study was propofol and benzo treated showed for alcohol withdrawal syndrome has similar length of stays, similar days of mechanical ventilation. I think this is likely another negative study for propofol because one, the patients that were in the benzo group, you can make an argument that they were likely more sicker than the people in the propofol group because they already required more benzo requirements than the people in the propofol group. But then even with that, there was still no difference in any of the outcomes. Propofol was no different when looking at mechanical ventilations. Like we said, alcohol withdrawal symptoms, length of stay. Patients in the propofol group received almost 4 times the amount of benzos. Sorry, I think I got that mixed up. So people in the propofol group have more benzos than the benzo group. So I mixed that data up. Sorry about that. But CWAL scores were still similar at presentation and prior to initiate the study between the infusion groups. So another study that I was looking at, so then there was the argument between propofol and Precedex, like which one is a better drug when looking at alcohol withdrawal syndrome. So they actually took propofol and benzos and it was another retrospective study that looked at 41 patients, and they looked at people who were already getting treated for alcohol withdrawal syndrome with a system-based approach with benzos, and they were either given propofol or they was given Precedex. And their endpoints were benzo requirements, haloperidol utilization. Some of their secondary measures was analgesia use, ICU length of stays, rate of intubation. So when they looked at between the propofol and the Precedex group, there was significant decrease in benzo requirements in both groups and haloperidol requirements in both groups. But there was a trend, there was no difference, but there was a trend towards a decreased ICU length of stay in the Precedex groups as compared to the propofol groups. Rates of intubation and time to intubation was clearly less in the Precedex group as compared to the propofol group. The incidence of hypotension were a little bit more in the propofol group than the Precedex group, and the incidence of bradycardia was significantly more in the Precedex group as opposed to the propofol group. So no other difference when the secondary outcomes were actually seen. So their conclusion was both are good for alcohol withdrawal, but you have to tailor it to patient requirements, unique patient requirements. But I take the study, even though it's a retrospective study, as that Precedex probably has a better profile for overall alcohol withdrawal in people who are meeting requirements for alcohol withdrawal. If you're looking for adjunct therapy, Precedex seems to have done a little better, or at least trended to look like it was going to do better. ketamine. So how does ketamine work? Ketamine works. Okay. Ketamine works. It's a central nervous system antagonist. It works on your NMDA receptors. Remember, alcohol upregulates your NMDA receptors. It downregulates your GABA receptors. Upregulates your NMDA receptors. So it actually antagonizes your NMDA receptors. So ketamine produces an anticholinergic kind of symptoms. That's why, and it causes bronchodilation. That's why they're used as induction therapy when people are trying to intubate with people who have asthma. So historical fact, Precedex was actually made from PCP. So back in the 1950s, PCP was used actually as an induction for analgesia, but the people were starting to get really weird kinds of highs, so they started to try to find another drug, and that's how ketamine was actually produced. It was actually used during the Vietnam War, and then it was actually marketed to more civilian use in the 70s. Yeah, I know, PCP. So ketamine as an adjunct therapy to benzos for the management of alcohol withdrawal. So this study was a look at ketamine pretty much in addition to benzo requirements. So what they did was another retrospective study for 3 years that looked at ketamine for the management of alcohol withdrawal. Their outcomes was benzo requirements or adverse effects associated with ketamine. So they looked at about 200 and so patients, and 23 only met eligibility. The mean time for initiation of ketamine from the first alcohol withdrawal or the total duration of therapy was 33 and 58 hours respectively. This was their infusion dose, 0.21 and 0.21 for the initial infusion dose and the median. And the median change of benzo requirements was, in the first 12 and 40 hours, was 40 and 13 milligrams of benzo. So it showed a decrease in the total benzo requirements, and it was well tolerated. Not much adverse events that was documented. Baclofen. So baclofen, it works on the GABA B receptor. So instead of your GABA A receptors, it works on your GABA B receptors. They don't really know the precise mechanism, but you know they do use it a lot in neurosurgery for back pains, stuff like that, because it works on your presynaptic GABA B receptors, causes hyperpolarization, and this hyperpolarization leads to decrease in excitatory transmission, and so you get decrease in muscle spasms. So baclofen. So this was a study that was done that also, this was a prospective study that was done in Minnesota that looked at baclofen as an adjunct therapy to people with alcohol withdrawal syndrome. So they looked at people who were admitted to the hospital with any kind of alcohol withdrawal symptom, and they pretty much either gave them benzos or they gave them baclofen 3 times daily, and then they looked at their CWAS scores and how much benzo requirements that they required. Pretty much to make it short, they showed that baclofen was associated with decrease in benzo requirements. So there were some studies, it's really case series and case reports on haloperidol as used as an adjunct therapy for alcohol withdrawal. But most of the concern for these were I didn't see any prospective, retrospective trial because most of them were really concerned about, a decrease in the seizure threshold and increased risk of QT prolongation. So you increase risk of arrhythmias associated with those. Do we still use beer? We don't use beer anymore in the ICU. I talked to pharmacy about this. They said that they don't even use it anymore. I don't know, some people can probably educate me on this, but when I asked them, they said they actually used to use ethanol for volatile acid ingestions, and it was just titrated it up to alcohol dose. So they'll make you legally drunk in the ICU to inhibit some volatile acids. And I asked, do we still have beer? And the answer was, we do still have beer, and they only use it for hospice patients. So somebody's having alcohol withdrawal, or in the SICU, which makes sense. But so this is the dose. I got a quick finish. Thank you, Dr. Gina Gray. Questions? Questions? No questions.
No questions.